Instagram, and share it amongst all the trainees as best as you can. So the lecture coming up is going to be by Simon Clint. Now, Simon Clint is a consultant colleague from Cheltenham who initially specializing in frames, but specializing in trauma and foot and ankle surgery. And he's going to be talking to us about the management of Pilon fractures and the use of frames in that situation. What I would ask is that during the lecture, there's definitely an opportunity for questions, and I would ask you to use the question and answer icon at the bottom of your screen in order to try and make sure we get through it in a nice, tidy manner, and then some case-based discussions at the end. So without further ado, I'd like to hand over to Mr. Simon Clint and welcome him to his lecture of distinction. Thank you, Simon.
Thank you, everybody, and welcome. As was so nicely put, I'm a foot and ankle surgeon predominantly from Gloucestershire hospitals. I have a mixed practice in both elective and trauma, and I am a frame surgeon as well. So, for some reason that's not working. Perfect. So the idea today is to give a half-hour talk on some of the principles of Pilon fractures, how they happen, how we classify them. What I find really interesting and relevant with Pilon fractures is how the management has evolved over time. So we're going to look into that and how that has fishtailed really into the current options that we have for surgical management. A look at the outcome and a look at some of the almost inevitable complications from treating these nasty fractures. So what is a Pilon fracture? A Pilon fracture is an intra-articular fracture that extends into the weight-bearing or the horizontal portion of the distal tibia. A pilon is the pestle, which is the pounding bit of a pestle and mortar. Pilon is French for pestle. The other description of these is a plafond fracture, and a plafond is just the ceiling in French again. So we have two French terms for the same injury. But from my point of view, what it really is it's a soft tissue injury that happens to have a tibial plafond, so an intra-articular fracture. But first and foremost, this is a nasty soft tissue injury. So, how do they happen? Well, the classic paper, which started really looking at treatment of Pilon fractures, was Ruedi Allgower from Bern in Switzerland, and they described axial loading of the foot with the talus impacting and smacking into the distal tibia. And if the force was applied directly under the talus was obviously clearly driven straight up, but if it was applied anteriorly or posteriorly, that force would either shear off the front or shear off the back. What's relevant about their paper, and will become more obvious later on in this talk, is they were in a ski area of Switzerland, and the vast majority of the patients they described were fairly low energy axial loading, often with a rotational or a shear component. In fact, they described 82 fractures, 73% of which happened with skiing, 23% with slips on ice, and less than 5% were what we would really classify high energy. And the problem is that isn't what we see in the UK, in much of Europe and in the States. We see high energy axial load. It's either people falling and crashing down, or unfortunately, road traffic accidents. You can imagine if your car hits a stationary object, the engine gets shunted back, your feet are on the pedal, you're going to get an amazing axial load applied through your talus into your tibia. So given that they're predominantly nowadays high energy injuries, the demographics, as you would expect, are those of high energy injuries. They're usually stupid young men, or men who are young and therefore stupid. It's that classic group. They're fairly unusual. They account for 1% of all lower limb injuries and only a small portion of all tibial fractures. But because they're high energy, it's not that uncommon. About 1 in 10, 1 in 20 are bilateral, but really noticeable is a quarter are open, and between a quarter and a half has some other significant injury, whether musculoskeletal or not. And that really just tells you that these are high energy injuries. And why is that significant? Well, if you imagine the talus is smacking through the distal tibia, that's a high concentrated load. And as the tibia fails and shatters, there's a transference of that energy from the muscle to the surrounding soft tissue. And unfortunately, around the ankle, there's very little muscle indeed. And really, it's just a little bit of adipose tissue, a few stringy tendons, and some skin to absorb that force. So it's not surprising that the soft tissues really take a pounding with these injuries, particularly the more higher energy ones. So patient comes into A&E, how are you going to manage them? And it's obviously, it's a management of a high energy injury. You need to resuscitate the patient. Contrary to what most foot and ankle surgeons may feel, A stands for airway and not ankle. So we really do need to think about the whole patient and not just our bit. Obviously, you've got to make sure there aren't that one in two chance of another injury. And then you've got to think about the leg. Look at the soft tissues. If you can, ideally photograph them so that the back slab doesn't have to keep on coming off. Stick them, check the neurovascular status. Pain control. A back slab is really good pain control. Give them something else and investigate and phone a friend. So first line investigation really ought to be some plain films. There is certainly in our unit, there's a tendency for A&E just to CT everybody, and we end up asking for plain films afterwards, because most of us still find them very useful. But plain films, and unfortunately A&E seem to be incapable of working out which end of a tibia is broken, so tend to ask for tibial views. But really you want a well centralized ankle shot, centralized on the ankle, AP and lateral. Obviously, if the fracture is extending higher, you'll need to extend higher. But a nicely centered AP and lateral view, that gives you a good idea of what you're dealing with. But nowadays, almost all intra-articular fractures get CTs. They're very quick and easy to obtain, and the quality of these new 512 or whatever 1024 slice scans is amazing. So really, the investigation of choice, once you've got your plain films and confirmed it is an intra-articular injury, is to get a CT. And some of my colleagues question whether we need to CT all of these fractures. And as you heard, hopefully with the posterior malleolus talk that Andy Malloy gave some time ago in this series, I really do think you need them. And there's a very good paper from the mid-90s from Tanetta's group, where they showed, I forget the number, but a group of surgeons, a collection of Pilon fractures, and asked them to estimate how fragmented the fracture was, how many fragments there were, and to make an operative plan. They then waited a couple of weeks, represented the same fractures, but with CTs rather than plain films. And yes, the CT showed more fragments, but what's really important is 64%, so 2/3 of these surgeons changed their plan on how they were going to fix these fractures based on the CT. And I think nowadays CTs really help for that operative planning, so you can work out the plane of fixation to get any compressive screws at 90 degrees to fracture lines. You can work out your approaches, and it really does help in planning. So please, please, please get a CT. So if you take one thing away for the exam from this paper, one thing away for the exam from this talk, it's this paper. It's one of the classic papers you really ought to be able to mention, or at least the classification system from it. In 1969, in English, and previously, I think, in French, a few years earlier, these two chaps from Bern, Ruedi and Allgower, who I've mentioned previously, published this paper. They published the results of 84 fractures they treated over in 82 patients over about a 3-year period. They were the first to really describe the mechanism, describe the fracture pattern. They classified it, and they outlined the principles of their treatment, which were to restore the length and the axis, usually by plating or fixing the fibula in some way, to put the articular surface back together. They were strong advocates of bone grafting just behind the articular surface, and then they tended to plate using fairly primitive AO techniques, because this was early on in the days of AO, plate the medial side of the tibia, predominantly to prevent later varus collapse and to support against the fibula. And they presented 84 fractures, and they had amazing results. Despite the fact that they described operative time between 40 minutes and an amazing 6 hours, and despite the fact they only gave IV antibiotics if the operation time exceeded 2.5 hours, otherwise no antibiotics were used, they only had 4 superficial and 3 deep infections out of 84 cases. And amazingly, on an average of less than 1 year, patients had returned to what they described as 100% of working capacity, and they had amazing 72% of excellent or good outcomes. Ruedi then published a few years later his 9-year follow-up of the same cohort. He could only track down 54 of the 82 patients, but he described an overall improvement in function was found and only exceptional deterioration. And he had a very nice way of illustrating that with arrows showing predominantly an upward movement. And this was despite what most people today would consider suboptimal fixation. So, and the one thing everyone really needs to know out of that paper is their classification. Thankfully, it's a good old-fashioned orthopedic good, bad, and ugly classification with 3 stages, so it's easy to remember. And basically, they described tibial plafond fractures either as completely undisplaced, as displaced but not highly comminuted, and highly comminuted type 3. Obviously, that's incredibly subjective. What is just displaced? What is highly comminuted? And as a result, it really is subjective and inaccurate. But it's an easy one to remember. And it's certainly the classic classification system for Pilons. As with any fracture, AO and the Orthopaedic Trauma Association in the States have weighed in and used their classification system, and it's just the same as all of these. You just need to know the principles. It's the end of a long bone 4, it's segment 3. Type A are extra-articular, therefore not Pilons. Type B are the partial articular, so something like a posterior malleolus fracture is a partial articular Pilon. And really, oops, sorry. Oh, what the hell's happened there? Sorry about that. And really, the majority of the literature and the majority of the talk concentrates on these complete articular, i.e. there's no bony continuity between the shaft and the weight-bearing surface of the distal tibia. More recently, Claire Topliss, who I believe gave you a lecture earlier in this course, came up with a CT-based classification of Pilon fractures. And this is a rather pragmatic classification system which broadly divided all the Pilon fractures they looked at, and they looked at 128 cases, into 2 families, the coronal family and the sagittal family, based on the orientation of the primary fracture line. They noted that the coronal fractures, i.e. where the primary fracture line was in the coronal plane, tended to be lower energy older patients, lower energy injuries in older patients, and had a tendency to present and collapse into valgus. The sagittal ones tended to be the reverse. They were younger patients, higher energy fractures, and they had a habit of collapsing into varus. But more importantly, getting the principle of this idea of a primary fracture line and where you need to get into the fracture to fish out any impacted bits or die punch fragments is really important. So using your CT to work out these primary fracture lines has become really important in working out how you're going to fix this. And in this paper, they went on to describe the 6 primary fragments, either the main anterior, posterior, medial, or sometimes you can get avulsions of anterior, lateral, and posterolateral. And obviously you can get a piece of articular surface punched up like a die into the metaphyseal bone. So, as I mentioned earlier, the evolution of Pilon management has come on quite a long way. And certainly before Ruedi and Allgower's paper, these were bad news. They tended to be treated conservatively, often with a calcaneal traction pin, either with skeletal traction or a pin built into a cast. And they were recognized as bad injuries and allowed to consolidate and then possibly arthrodesis at a later date. And it was really only with Ruedi Allgower's paper, which unfortunately initially was in the European literature, and then it was in the first ever volume of Injury, and therefore not read much in the States. And it was really only when they represented their work in current orthopaedics and related research at the end of the 70s that it was popularized. And suddenly everyone started fixing these. And unfortunately, nobody could really reproduce the amazing results that Ruedi and Allgower produced. And it became clear over time that that was because they were treating RTAs, high energy falls, rather than ski resort injuries. And they were really struggling with infection rates. Some papers describe soft tissue infection rates of 25, 30, 40%. So everyone jumped on the AO bandwagon. It was a real expansion of the principles of rigid internal fixation and compression, interfragmentary compression. Everyone tried it. And then by the 90s, people were getting a bit twitchy about this, and they were seeing lots of infections, lots of wound breakdowns and problems. And about that time, there was quite a resurgence or a development in different types of external fixators. And this was about the time that some of the ideas from Elizarov were beginning to appear in Western medicine. And different companies were producing different types of external fixator. And people were thinking, if we could just piece the joint back together and then hold it all out to length, often with either a bridging external fixator or a hinged external fixator, perhaps we can get the joint back together and hold it all together and allow it to heal without the soft tissue problems. Bone published his results on this, and he had greatly reduced soft tissue problems, as you'd expect, because there's not those big incisions. Unfortunately, there was a higher rate of malunion and non-union of the fracture. And these findings were reproduced over time. And it was really only about the turn of the century that people started thinking about the ideal combination of the two, treating this acute soft tissue injury with an external fixator, really to stabilize the fracture and therefore stabilize the soft tissues, allow the soft tissues to settle, and then 7-10 days afterwards, once that acute inflammatory response had gone, once hopefully the blisters have reepithelialized, once the soft tissues have settled, going in and fixing them. And that's really what most of us think is kind of contemporary management. And several papers from lots of big trauma units have come out showing very good low infection rates with high energy injuries and with open injuries, with this staged external fixation and then later fixation. And it's really only been in the last decade or so, I think one of the earliest papers was Tim White's paper from his work whilst on fellowship, where some units were beginning to move away from that and thinking, do we really have to put an X-fix on every pilon, and can we select out certain certain fracture types, certain soft tissues, which we can safely go in day one and fix them? And he produced data where they were trying to fix them on within 24 hours and certainly within 48 hours, and showed comparable infection rates. I think it was 2.7% soft tissue infection, no, deep infection in their cohort, which was very comparable to the published literature on staged treatment. So some high volume units have got the capacity to treat these on day of presentation. But I think in most units, and certainly your average DGH, the treatment is staged still. So irrespective of when you treat them and how you treat them, the principles are the same, whether you use a fixator or anything. Number one is these soft tissues have had enough, don't mess them around anymore. Number two, it's a joint, put the joint back together. Number three, joints are better attached to a leg, so stick it on the leg. And four, fix it all well enough that you can get that ankle moving. Because if they end up with a completely rigid ankle, you may have well fused it. You might as well fused it at the beginning. And what can help you choose your surgical management? Obviously the state of the soft tissues. If there's a massive, great, almost degloving, you're not going to make a huge, great cut in there anytime soon. The fracture type, is it a nice straightforward fracture? Is it a pile of mush? I think what's really important is the patient type. Are they the kind of patient who you wouldn't trust to do anything right? Or are they the kind of diligent patient that thankfully we have a lot of in Gloucestershire, who are educated, realise they've had a bad injury and want to do everything to help? And that's really important, getting to know the patient. Don't just pitch up post-ward round and just decide on what you're going to do. Chat to the patient. I've put surgical skills available in brackets because I really don't think that should dictate how you're going to treat a fracture. If in your unit you don't have the skills to treat these injuries, stick an X-fix on, get in touch with a local specialist who can help you and ship them down the road, because I'd much rather see them then than 4 weeks later with metalwork sticking out of a pussed out wound. Unfortunately, in terms of deciding how to fix them, there really is very little level 1 evidence. There are a few very low numbered RCTs. A lot of them are historic and really can't help us make the decision. And most of the data is based on cohort studies and often not comparing similar fractures. And why does this choice of fixation matter? Well, it matters because different choices affect the soft tissues. Different types of fixation will dictate how long you want to immobilize the leg and when you're going to let the patient walk on it. So I'm just going to quickly go through the various choices, and hopefully in the discussion we can flesh some of this out later. But delayed internal fixation, the classic modern treatment, has got lots of advantages. The main one being that you can treat the soft tissue injury and then come back fresh as a daisy to treat the bone injury. By putting an X-fix on the fracture and dragging it out to length, it means you can get better CTs because everything's aligned. Sometimes the CT straight at the time of injury in A&E has so many bits everywhere, it's difficult to work out what you're going to do. If you pull the leg straight, everything looks a bit more like an ankle. And also importantly, you can get the right surgeon doing the right operation at the right time. It buys you time, either within your unit or your friendly trauma centre down the road. Disadvantages, obviously it's going to immobilize the patient longer, slower return to function. There is this concern about the pin sites with colonization of the pins where they go into the skin. Certainly if you swab any pin site, you'll get bugs. There was quite a lot of concern about this. And certainly I was always taught that keep your pins well away from any bit you might want to operate on. More recently, there's been a couple of good papers showing that the actual infection risk may not be as high as we fear. And even if your implant, your internal implant, happens to bridge where your external fixator pins were, the infection rate doesn't seem to matter. And finally, obviously, there's a disadvantage of 2 trips to theatre. The principles, well, very briefly, it's span, scan, and plan, just as I've said. You do want to keep pin sites away, and ideally have a word before you take the patient to theatre and chat to the surgeon who you think is going to be fixing it. Because if they can quickly eyeball a plain film, they may say, please do this, please don't put your pins here, etc. There's a debate about whether we should be fixing the fibula at the time of stabilization. The advantage is it adds some stability to the construct, but also it helps restore length. And often if you've got quite a simple fibular fracture, putting it back together can help re-establish the length of the leg. There are papers showing that it really doesn't make that much difference to the outcome, but certainly there's increased wound problems, particularly with a badly placed incision for a fibular plate that either gets in the way of future fixation or causes wound necrosis. And also, if you fix the fibula and get the rotation wrong, it's going to make the tibia unreducible. So, when I was appointed as a consultant, this is how I treated all my Pilons, pretty much. I was putting Alizarov frames on. I'd just come back from the Alizarov Center in Kurgan in Russia, and I thought they were brilliant. They've got lots of advantages. This isn't the best picture I found, unfortunately, but so my standard treatment would be to make small incisions centered over the primary fracture lines, put 1 or 2 cannulated screws in to restore and reduce the articular fractures, and then put a frame on. The advantage, frames are jolly strong. You can get patients weight bearing on them very early, which helps with bone healing. They're very respectful of the soft tissues because you've only got pin sites. And if you need to, if you've got an awful lot of comminution, you can do clever things like bone transport, or more commonly acute shortening, and then bone lengthening at a later date to restore length. There are lots of disadvantages. You do need team support. When I started, I was incredibly lucky to inherit a couple of very keen physiotherapists, some scrub nurses who really enjoyed doing them, and most importantly, a specialist nurse, because you will get a lot of phone calls about frames. And that's partially because pin site infections, I think if you're honest about them, are almost inevitable. You very rarely find a patient who has a frame on for 4 or 5 months who doesn't have a slightly inflamed pin site, often around the knee. And usually, for various technical reasons, you have to span the ankle to begin with, and you have to put fixation in the foot, which again stops you getting early motion. A few simple technical issues. Part of the problem with ring fixators is if you look at this diagram, we talk about segments with frames. So this solid bit of tibia is a proximal segment, sorry, and the distal segment is the highly comminuted bit. And ideally, you want a ring on each, at least 1, preferably 2 rings on each segment. Clearly, with most Pilons, you can't get 2 rings on, so you have to have a second ring down below, i.e. span the ankle. And unfortunately, because of the synovial extent of the joint, particularly in the fibular recess, it comes about 1.5 centimeters up from the joint in that syndesmosis. So unless you want to play risk of septic arthritis, any wires have to be kept out of that. So if you've only got quite a short fracture and you've excluded the bottom 1.5 centimeters, you haven't got much to hold on to. Also, low down on the ankle, there's quite limited safe corridors for passing your wires, because you've got the classic wire from the fibula through the tibia. If you encroach slightly posterior, you can get the peronei, you can get the saphenous nerve on the other side, and certainly a lot of the wires that come out the front at best can tether tendons or muscles, and at worst can hit some big stringy things such as nerves. So technically it's quite demanding. But certainly in the right hands, it's a very useful tool, and a lot of surgeons, including myself until recently, it was a mainstay of treatment. Prof. Sharma in Hull University is trying to produce a decent randomized control study. I think they're trying to recruit over 200 patients from something like 30 units and also some international units. As almost all modern randomized control studies, it is a pragmatic study. And like all big studies, it's got an acronym, the ACTIVE trial, which is the articular type C Pilon fracture trial, internal versus external fixation, which I think they've really struggled to make a word out of. But it's the ACTIVE trial. They have started recruiting. They're hoping to finish data collection in 2 years' time. So hopefully in about 3 years' time, we should have some good data to say whether we should be using locking plates or external fixators for these fractures. Immediate fixation, just briefly, it's got the advantage of reducing the duration of immobilization, obviously, because you're not sticking them in an X-fix. People argue that if you get to the fracture early enough, you reduce the tension on that soft tissue. So although it's taken a force, you're getting the fragments that are tenting that medial, in particular, that medial skin, and reducing that. And obviously it's a single procedure. The big disadvantage is you need skilled surgeons who can operate that day or the following morning and not at the end of the week next week. So you need decent access to theatre and a decent number of surgeons who are comfortable doing this operation, so it doesn't all fall to one particular surgeon who has a list every second week. Just briefly, I want to touch on a reduction principle that we can go into in a bit more detail, which is metaphyseal reduction. Unfortunately, the AP image looks awful there, but this is a fairly typical Pilon. If you get your CT at the joint line, it's all really horribly comminuted. And I don't know why these are looking so awful. I'm sorry about that. But if you come just 10 centimeters up from the joint line, that horribly comminuted fracture has really simplified and has only one spike. And if you just put, this is just a 1/3 tubular plate I've just put in, just really as a buttress to hold that simple spike proximally, suddenly the fracture is a whole lot easier to fix. And you can use, here I've used a little hand plate as a rim plate to piece together a lot of that anterior comminution, and just a couple of simple cannulated screws. And I was happy with him weight bearing within about 8 weeks, and he was moving the ankle within 2 weeks. Finally, I realize I'm a bit tight for time, but primary arthrodesis, it is an option. For those joints that there's just nothing to piece together, if you can hold it into a leg-shaped leg, it can save you having to do an arthrodesis later on. Clearly, it sacrifices a joint that you may have got away with saving, but it does avoid a second operation. If looking at the state of the damage, you think that's where it's going to head towards. So what about the outcomes? These are great fun to fix. I love doing them, and I think I'm great at them. But the outcome really isn't good if you look at the literature. Pollock, I think I've missed a L out of his name, Pollock looked at quite a number of these and looked at the impact on quality of life years. And amazingly, a Pilon does worse than a pelvic fracture, does worse than AIDS, and this was a paper written in turn of the century when AIDS was a really terminal illness, and heart disease. So these really impact patients. And rather depressingly from his paper again, at mean follow-up of 3.5 years, almost half of the patients were unemployed, and 2/3 of those unemployed patients attributed their unemployment directly to their injury. So these are life-changing, devastating injuries for patients. And what affects that outcome? Well, it's threefold. Obviously, you've got the injury itself, you've got how much energy, how comminuted, what the soft tissue is like. You've got the patient factors. Are they an alcoholic, smoker who isn't going to listen to a word you say, and diabetic who wound isn't going to heal? Or is it a highly educated patient who is going to listen to every word you say and will do exactly what you want? And finally, despite every single orthopedic surgeon thinking they're brilliant, 50% of us are below average, and not everyone has the same experience, and with experience you get skills. So what do I tell my patients? The first thing I tell them when I see them is I can't undo what happened the minute your foot hit the floor. All I can do is try to move forward from where we are. And I tell them, for me, I will be over the moon if they tell me they've got a stiff ankle that only hurts occasionally. I say I'll be unhappy if they tell me that they've got a stiff but painful ankle, but I can do something in the future to help them with that. But I warn them that we could get an awful outcome with chronic infection or chronic pain, and we end up having to amputate the leg. So I must admit, I'm fairly pessimistic when I consent people. I lay it on fairly thick, and I do warn patients that these are really bad injuries, because then if they do well, they think you're brilliant. If they don't do well, you've already told them. So what are the common complications? Really, these fall into infective complications, superficial wound complications. In different series, it's anywhere from 5% to 40%. A lot of these series mix up open and closed injuries, but probably in the region of 5 to 10% of patients will have some erythema around a wound, some slightly delayed wound healing. And I'm very strict. I keep them immobilized in a plaster until I'm 100% happy that the wounds are mature, and then I get the ankle moving to stop putting any tension on those wounds. Unfortunately, deep wound infection with osteomyelitis, septic arthritis does occur in papers anywhere between kind of 5% and higher, all depending on the level of open fractures. Stiffness, I think, is almost inevitable. They're never going to regain full range of motion with an intra-articular injury. I'm happy if they are stiff when you examine it, but they don't notice it day to day. Post-traumatic osteoarthritis is interesting. A fair number of people develop radiological changes of arthritis quite rapidly. Interestingly, outcome in terms of patient-reported outcome measures doesn't seem to correlate that much with the degree of arthritis in their ankle. And actually, the arthrodesis rate following a Pilon fracture is actually far lower than you would guess. It's about 5% at 10 years in a lot of series. And the other complication is non-union and malunion. These tend to occur hand in hand unless you fixed it wonky to begin with. The non-union almost always occurs at the metaphyseal diaphyseal junction. An articular non-union is exceptionally rare. And what often happens, if you've got a plate, say on the medial side, you get a non-union, that plate breaks, and then the fracture collapses into valgus if it's on the medial side, and then consolidates, giving you a malunion. We will skip that part and say, please, please, please remind your physio team that they are not dealing with an ankle fracture. It's not helped by often discharge summaries writing it down as ankle fractures, but this isn't an ankle fracture. It's a very different beast. So in summary, and sorry I've overrun a bit, these are high energy injuries with devastating impacts to patients, and the patient needs to know that from the off. The surgical management is continuing to evolve, but we seem to have reached a fairly happy balance without a great deal of level 1 evidence for balancing the soft tissue demands and the bony demands. I know it's a glib comment, but a bone is only as good as its surrounding soft tissue. If in doubt, span, scan and plan. Wait for those soft tissues to recover. And please, please, if you're not comfortable, pick up the phone, because there's lots of us who love doing these. Thank you very much. Just briefly, this is a photograph I took in the Elizarov Museum in Russia. This is intraoperatively, because they do all their cases under spinal. Here's Elizarov himself having a no-touch technique fag. And I love the fact that the patient's also having a cigarette, and the anaesthetist is holding his hand up to let him have a cigarette. And he reported no non-unions. Thank you very much. Any questions?
Fantastic. Thank you, Simon. What a great and thorough run through over Pilon fractures. That was awesome, mate. I'm very grateful indeed. There's been a few questions come through. One very practical one has come in, and that's to do with the X-fix you would like to have put on by your colleagues in the middle of the night. What kind of construct do you prefer to have? An A-frame, L-frame? What would be your ideal construct you'd like to have put on?
Ideally, I would like an A-frame. I would like 2 pins in the tibia, as proximal really as you think you'll get stability. Not so much with a low fracture, but a lot of these fractures go a long way up, and there's nothing more infuriating than slightly mucky pin sites, exactly where you want to put a plate. So pins nice and proximal, a calcaneal pin, construct an A-frame. What I like to tell people to do, particularly in the elderly, if they're sitting around on a ward for a week, particularly on a non-surgical ward with a heavy X-fix on, they can get pressure sores on the heel. So I always tell people to make the medial lateral rod slightly long, and put a crossbar there just to lift the leg off the bed. It elevates the leg, and unless it's only going to be on for a day or so, I mean, almost inevitably, please put some fixation either in the medial cuneiform or probably more sensibly the first metatarsal, and attach that to the frame to avoid an equinus contracture. Okay.
Preferring that rather than the unilateral down on the medial side, or alternatives there, just the A-frame construct.
The A-frame,
nice, rigid and strong.
It's really rigid, it's strong, it's going to cope with dressing changes on the ward. The nurses aren't going to worry about it. It's easily teachable, and also you can get a very strong construct leaving a decent gap away from the soft tissues. A lateral X-fix needs to be fairly close to give strength, and therefore you're limited with soft tissue care. The nice thing about an X-fix is you don't need any dressings on, or you just need dressings to treat the soft tissues, so that the nurses can keep an eye. And
you mentioned in the talk about this span, scan, and plan concept. We have a few people asking the same question, actually, which is, what about this concept I often see this at work, which is the scan, span, scan, plan. So they're often scanning it immediately in casualty, putting your X-fix on, and then we're thinking we should scan again now to see what we're dealing with. Do you find that common?
Unfortunately, we get it in our department. I'm desperately trying to persuade. I think often it's ED thinking they're being helpful. Often it's a registrar thinking that I'm going to go ballistic tomorrow morning if there's not a CT for me to look at. Therefore, let's keep grumpy Mr. Clint happy. But I really think, I mean, there's an impressive radiation dose. It's something like 250 chest X-rays from an ankle CT. It's not insignificant. I may be making that number up, but it's a significant amount, and we shouldn't be irradiating patients twice. that initial non-spanning fracture CT really isn't as helpful as the one in an X-fix.
That's my practice as well. Is whatever happens once they've got the X-fix on to do it. Do you think there's any role for MRI in Pilon fractures?
I've never used it, I must admit. I can't really think of one. You get so much soft tissue edema and everything from the fracture, and MRIs are useless at looking at fracture configurations. So no. And
you keep your X-fix on during the operation. Do you ever keep the X-fix on afterwards?
So depending on, I don't tend to. So the X-fix is a really useful reduction tool, but I don't like the idea of all the clamps that have been sat on the ward. So what I often do is take the X-fix off and change it for a good old-fashioned AO femoral distractor, which you can attach the calcaneal pin, you can attach the tibial pins, you can place it well enough away. I don't tend to leave a frame on, because for me, the reason for internally fixating these is to get them moving early, preferably at 2 weeks, and trying to coordinate a return to theatre. Obviously, if there's awful bone, what I have done in the past is internally fixated these and then put an simple Alizaroff frame, because I can take a simple wire frame off in clinic. I can't take a unilateral external fixator with bone pins off in clinic.